Thank you, Joe.
Yes, sir.
Yeah. Robin, thank you for the opportunity. Good morning. Peter Buckley is my name. Good morning, Delegate. Particularly Delegate Deeds, thank you for your leadership. And all of you, thank you for your leadership, as well as for the opportunity this morning. This is a opportunity that we have grasped with great enthusiasm, and already the interaction has been very good. I'm new to this Commonwealth, and so it's all a learning experience. And I asked Joel, just after Joel talked with his wife this morning, I asked Joel, what should I talk about this morning? And Joel said, talk about 3 minutes. And so I will be a little more than that. And I will cover some ground that I suspect will be known to you, some ground that may raise some eyebrows, and hopefully provide some information that will stimulate our continued discussion. One of the things that appealed to me greatly in coming to this Commonwealth is that this is amongst the amongst the states in America. It is both the founding state and a leading state, and has always been. And I would like to be part of us leading in mental health. We have a long way to go, but I believe that is the resonance of your commission, and in many ways never to waste a crisis. And so we have a daily crisis in mental health and an obligation to do our best about that. And so I'm going to take the focus on workforce development, and it will hopefully answer some of the comments and questions that came up already. Dr. Rao indicated that we are indeed partners, but we are also neighbors, and so we very much appreciate the opportunity to be able to come and engage in dialogue. And it was in the 180 years of our medical school, it was the first time that a sitting governor, a physician, came and lectured about mental illness, in fact, to our medical students just 3 weeks ago. And so this is like a return visit, and we feel very privileged both to have the legislature that serves our Commonwealth as well as the relationship that we have. And Joel, you were spared this morning because Joel did not take you through the 180 years history of our institution, but we have been around for a long time, and our 4 founding fathers would be delighted with the kind of doctors that we produce. And I will say more about that when we talk about the psychiatric workforce. What I'd like to cover fairly briefly and leave time for discussion is give you a kind of landscape of mental health statistics. I think you will be aware of some of these, but I'd like to drill down a little bit more because they really balance out the issue of need and supply. And in essence, that's what our dilemma is in trying to provide optimum healthcare services, and particularly the issue of access. And so I'd like to provide you some information on that, and then some thoughts about how we may do better, including what may change the landscape for us into the future. We are, in general, when you look at the number of doctors produced in America, we're underproducing doctors relative to the total population, and then the aging of the population. And we've been relatively in stalemate while we've increased the number of medical students, and this Commonwealth has also done that. We've held relatively flat at particularly a federal level in funding the next stage of somebody's training. The reason why that's relevant is because it's a long and arduous task to become a doctor in the first place, and then if you go on to specialize in another area, it is even more difficult. We're here talking about mental health, not about cardiac surgery, and mental health is undersupplied. About 4% of medical students go in to be psychiatrists. And so when you think about the access issues and the availability of people to work with schools delegates, it's also a pipeline issue, the ability to grow and have the workforce that we need to supply the demand. These are some data on the workforce of both physicians and psychologists in our state. And you'll see there is about 1,700 psychiatrists and about 2,500 psychologists. And this is the distribution of other doctors. In general, about 21% are international medical graduates, and this is a state that welcomes international medical graduates. And it's surprising, but it's a repetitive finding that more international medical graduates find themselves in psychiatry than in other areas. So it's relevant to our workforce. These are some statistics on what Virginia looks like with respect to its healthcare in general and in particular to mental health. And I have indexed the mental health broad brush statistics in red because they should be in red because they show a danger to the Commonwealth and to its citizens. And we rank 12th in terms of poor mental health days. We have an overwhelming addiction epidemic that you already know and will hear shortly from Dr. Terplan regarding that. And the national eye has been on this state repetitively for its mental health programs and crises, including, of course, Virginia Tech, including Senator Deed's own tragedy, and as late as yesterday in the papers, ongoing concerns about mental health in the correctional and jail system. Senator.
How do you define a poor mental health day?
It's a composite measure drawn out of national statistics, so it relates to a composite on depression. Yes. These are high-level indicators. They're not as sensitive as to whether someone has an alcohol or addiction problem.
3.3 days per person or per year or per?
It's not per person. It's overall per population. Let me give you some information on the drill down on the mental health side of things. These are national statistics, and then I will share with you some statistics that are direct for the Commonwealth. Dr. Rao actually cited these at a high level, and these are very consistent. They just provide you a little more information. You heard about the concerns in particular with respect to childhood mental illness and distress, and how that, of course, can grow and perpetuate into adult. You will hear again from Dr. Terplan much more than I about substance abuse, but a real problem for our field is that substance abuse isn't a standalone and then mental health problems are something else. They're commingled, which makes it very difficult. And one of the phrases we use in our treatment is kind of double trouble, the difficulties of both mental health and addiction that are synergistic and compound. These are very high in people that are homeless. They're very high in people that are prison or jail inmates. And mental health is an enormous economic cost to the Commonwealth and to America and globally. And more than that, it is a serious cause of loss of life. It's in fact the second leading cause of loss of life in youths, and between 18 and 20 veterans lose their life daily through suicide. So these are staggering statistics. Dr. Rao actually referred to this. There are 2 points in this information. First is that many people that have mental problems are not in treatment, and it could be a multitude of reasons: access, availability, lack of insight, multitude of reasons. But there are more people not in treatment and many that are unaware of the need for treatment than there are actually in treatment. Secondly, Dr. Rao mentioned that while you look at the figures about the amount of mental illness it is more so in our midst, and again perpetuated more in people that have physical problems. So a very obvious example that will resonate with all of us is that there's a high rate of depression in people that have cancer, but there's also a high rate of depression in people that have neurological conditions, stroke, Parkinson's disease, and those interactions worsen our ability to manage the primary medical condition like stroke or Parkinson's disease. I think this is just one reason of many why this state has the opportunity to lead in the nation in terms of Medicaid expansion, because it will necessarily focus the lens more on the totality of healthcare for those most in need, both physical healthcare and mental healthcare, which, given the issues of both prevalence and comorbidity, are, I think, a great opportunity for us. Another reason why they're a great opportunity and why Medicaid expansion is timely is that our system, at least ranked nationally, is not holding steady. It's actually declining compared to other rankings, and these are national rankings from Mental Health America, where in 2011 we ranked 27th and we slipped to 38 in 2014. These are rankings closer based on the National Association for Mental Illness, NAMI, and a quotation from NAMI, Virginia, that in 2007 we ranked 42nd in the nation for access to care. And part of that in this report is that the lack of trained professionals, there is a lack of trained professionals, particularly for youth delegates. So what does the profile look like in terms of the professionals that provide care for mental health? And it is not simply a physician in the form of a psychiatrist, an adult psychiatrist, an addiction person, or a child psychiatrist. It is a number of professionals from counseling, from pastoral counseling, school psychology, psychiatry, marriage and family therapy. It's a very broad array, and it's a diverse population. And we do best in treating those conditions when we come together in a multidisciplinary manner, which means, of course, that there needs to be enough of each specialty to be able to bring that together. These are the data for the workforce numbers for psychiatrists and psychologists, which I showed you earlier, social workers and licensed counselors. And they are not uniformly distributed across the mental health system, and typically public health systems where people get more to care tend to be more stressed and have less staff, and the staff tend to come and go. And of course, all of that ultimately with that fluidity results in services that are harder to put together, which consequently result in delayed access to care and treatment and to the rankings that I showed you earlier. So what might be some of the things to consider in terms of ameliorating what many think is a fundamental workforce shortage as a deficit underlying our ability to provide optimal care? There is certainly a disproportionate and a great need for child psychiatrists. We're simply not producing enough child psychiatrists. And to your point, Delegate, which was a great point, we should be in the schools, we should be doing screening. We're in the clinics at the moment because we don't have enough people to go to the schools. We don't have the workforce to be able to expand towards primary prevention. So we're at the stage of treating situations as opposed to heading them off earlier. And that's a direct consequence of not having enough staff, mental health staff, to meet the overwhelming need and to screen for that. We also have dichotomies within our area that are substantial and meaningful. So we have differences between how we think about mental health issues and how we think about addictions. Many people think that addiction should be treated psychologically without any medications, and that medications are a shortfall, are a sign of weakness in treatment of addictions. Many people have comorbidities, so you can imagine if you have the need for a medication, but yet somebody that's involved in your care thinks that that's a sign of weakness, you may be managing the addiction but not managing the mental health problem. So we have some internal inconsistencies. We probably need a lot more psychiatrists in the consultation. Delegate, you asked about the 600 substance abuse, and they were also embedded, as Joel mentioned, in the consultation liaison. Imagine if you had somebody that was coming in for heart problems and we discovered that they had an addiction problem, and that's what was impinging on the heart problem. We'd be able to intervene earlier than letting the addiction problem take its course. And so that's another area of opportunity for us. The payment and salaries for psychiatrists are a lot lower than other specialties. Obviously, people choose their career and their what they want to give their life to on more than issues of salary. But nevertheless, salaries do matter, and medical students come out today with a $166,000 deficit, and so they are thinking around how do they make that up, and it does influence choice. And in the financial realm, psychiatry does not sit as a bedfellow with neurosurgery, and so it is an issue. That's why loan forgiveness programs are used in other states, particularly more so for primary care for family doctors, because family doctors and psychiatrists, the financial issues are fairly similar, but it's also applicable to mental health. I mentioned the issues of public versus private, and salaries tend to be larger in a private practice, like any other physician practice, than in the public system. Although many public systems spend a lot of money on locums because they have to fill positions. The issue about our training is important, and we need to do more to make sure that we are providing integrated care, that we are training in that kind of multidisciplinary workforce that makes sense in terms of when people get out into practice. And then we had a delightful experience about a week and a half ago. We had Secretary Carey come and tour our new building, and he asked us about quality metrics in psychiatry, and that is a very important area because we need to be able to hold ourselves accountable for the outcomes that we're seeking. We also have the issue of to what extent we train and focus in psychiatry and grow psychiatry and also support resources in primary care, because family doctors very often are people that first see problems, whether it's childhood anxiety or depression. And we need to remember the VA. About 70% of doctors that train in America have trained through the VA, and so the VA is not only a great source of workforce development, but of course it is a great source of psychiatric illness because of the unique stress of people that have served our country, and we have an overwhelming responsibility to provide the highest quality of care to those individuals. I mentioned the issues of pipeline, and I mentioned that international medical graduates are overrepresented in mental health. About 4% of medical students go into psychiatry. And you've heard us talk about the new building, and we are both grateful and proud. But I want to put another aspect to this, there's nothing more scary from a young medical student than to visit a state hospital that seems old and seems like it looks like a prison. That's a huge turnoff for that individual in terms of their thinking about, would I like to work in this place when I become a doctor? And so having a new face for mental health that quite frankly, Joe, looks like you're going to go skiing. That may be a bit of a misrepresentation. But having a new face and a new environment that offers hope, that is upbeat, that, as you mentioned, Delegate, is connected with the environment around, is all not just powerful for the recovery of people, it's also an induction for people who may consider this, and our students, whatever careers they are potentially future providers in mental health. So that's another thing that we're very grateful for. I think it's great that Dr. Melton is the commissioner in large part because he has a great understanding as a primary care doctor. That's his basic training, but he has a empathy and an understanding for mental health. And some of the issues in terms of workforce development are very congruent with the issues of mental health, just as they are in primary care. And on the right, you will see the summary of proceedings from an educational summit at the Carter Centre. Mrs. Rosalind Carter's well acknowledged as the greatest advocate for mental health in the country. And these were the summary of 5 key points, and I've enumerated them here on the other side. So the importance of us being able to develop interest and a pipeline in students. When they have choices, we need to be able to instill in them the interest in mental health, the optimism that it's a good career opportunity and that they can do well and be satisfied in that career and that they can make a difference in their professional lives. We need to be able to take programs that are optimum and integrated in training all the psychiatric workforce, and then we need to pay attention to particular areas. Forensics is always important. That's why you see correctional problems, both because of the overlap and then also the important political context of that. We've already highlighted the importance of child psychiatry in the broader area of developmental pediatrics. I said something about consultation liaison, which is really the overlap between physical and mental in hospitals and clinics. And then we need to do a better job blending with addictions so that we have dual track training. I was looking forward, Delegate, to tell you about this issue in relation to your question about getting into the schools and screening kids. And Joel mentioned that we need to be doing a lot of things and we need to be accessing every opportunity. And communications, of course, have changed greatly, which present an opportunity for us. And I'm particularly proud of Australia, which has a primary prevention for serious mental illness, a social media that represents a platform that then people can get into care and get access to care early on before their mental health problems snowball. And so we have opportunities in the realm of social media. We obviously see a lot of mental health issues on social media, and we have an opportunity for that to be a gateway. We have an opportunity to harness mobile technology. So for instance, one of the greatest problems in mental health is people forget to take their medicine because for a variety of reasons, but they forget to take their medicine. And I'm proud that mental health is leading the way for physical health also by the first web-based technology for an antipsychotic medicine where a person wears a patch, and then when they take the drug, when it's digested, it emits a signal to the patch that then can be translated to the person or the doctor or the family member's computer that you can monitor directly the person's taking of medicines. And so there are opportunities. All is not lost in the swell and numbers and prevalence of mental health. There are great opportunities, and these are some of the other opportunities that I believe are before us. Dr. Silverman mentioned the importance of telemedicine. It's particularly important to be able to reach out into rural communities that don't have the workforce that may be in an urban community. Telemedicine has been undercut by payment issues and by regulatory issues, and they're making their way forward, and that is an opportunity. I came from Georgia, and I was very proud that we had a large peer support workforce that we also co-opted to train our medical students and our residents. And this is a new form of workforce that's very exciting in mental health. It's been around in another guise, and that is in AA. People that have a sponsor are not the primary source of treatment, but they're an incredibly great support because they've traveled that journey. And we have now in mental health taken up that banner and have people themselves that are in recovery from mental health help others with mental health. And that is a terrific opportunity that this Commonwealth also is taking on board as we look at our workforce. One of the greatest problems, if you go back to Delegate and your comment about childhood problems and anxieties and depression, is that, of course, anxiousness is very common in kids, it's common in adults, but all anxiousness is not mental illness. And so we have great difficulty trying to put our finger on what is major depression versus what is a fleeting mood problem. And we don't have markers. So for instance, if you have chest problems and you're going to develop a pneumonia, you will get a test of your sputum or you'll get an X-ray and somebody will say this is this type of pneumonia and they'll give you this type of medicine to treat your pneumonia. We're still very much at a trial and error and shotgun stage because we don't have what are called biomarkers, which are measures that says it's this condition or it's that condition. We're on the way to getting them, I believe, and Dr. Silverman and our colleagues at VCU are world leaders in the genetics of serious mental illness. And as we better understand the genetics of mental illness, therefore we better understand simply what we're treating, and then that allows us to tailor our treatments better. All of us have watched in the last 15 years a revolution in the treatment of cancer where you do genetic tests particularly for breast cancer, and then you decide how you're going to treat that individual based on their genetic profile. That is not fairy tale, that is in treatment, and I believe that is ahead of us in mental health. We're not quite there yet because the brain is inordinately complicated. We always have the opportunity that goes with that of better tailored medications that are more selective and that kind of get to where the point is. And then we have the opportunity, this is highlighted a study we did some years ago, and this is simply looking at brain retraining on computer that's been done for people that have had head trauma and helps get their memory and their attention and their cognition better. And there is work that may also be helpful for people with serious mental illness. And so while we have a steep climb ahead of us, we have many opportunities as well as many current and emergent tools that may help us. And I'm particularly both proud and pleased to have come to the Commonwealth at a time when we have a physician as our governor and an administration that is placing particular priority and importance on the health and well-being, particularly the mental health and the addictions well-being of the people in the Commonwealth. And so I appreciate the opportunity to share some information with you. I'm open to any comments or questions now or at any later time. Thank you for your efforts and thank you for the opportunity. Senator.
Doctor, can you make this presentation available to us?
Yes, sir.
Absolutely.
We'll be sending to all the members and all everyone in attendance all today's presentations electronically.
I'd love to be able to drill down on some of those numbers,
Yes, sir.
statistics, and figure out, put them in context and try to understand what they mean.
Yes, and you will also have everyone's contact information with each presentation as well, sir.
Thanks very much.
Privilege. Thank you.
Senator Barker.
Excellent presentations. Thank you very much for that. I want to run through a series of issues and put together sort of a list of types of things
Yes.
that I think are relevant to what you're talking about there and are relevant to what we're trying to deal with from a variety of perspectives here.
Right?
Excuse me, some of which are things that are specific to Virginia, some of which are national
Yes.
issues, but which we at the state level certainly have the opportunity to try to make things better, at least in Virginia, even if we can't correct the national dynamics in many instances. One of the things I think is significant is the shortage of residency slots that we have in Virginia.
Yes, sir.
We did a study a couple of years ago where we determined basically to take care of every graduate of one of the 6 schools in Virginia who's coming into, has to head into a residency program, and our share of FMGs, which you point out are particularly helpful in terms of the psychiatry services, we would need to basically double the number of residency slots we have in Virginia because we don't have enough. Consequently, many of the people who go to medical school in Virginia can't get a residency slot in Virginia because there aren't enough and have to go somewhere else. And guess what? They don't come back. So we are spending money to help train them through their medical school, but not in a position where we're benefiting from that long term. We actually have now instituted a program where we're providing funding through Medicaid for additional residency slots in Virginia, and we took care of a little issue that related to VCU and UVA and
Yes, thank
CHKD this year to provide opportunities for you to participate as well. But we need to build up, the residency slots to be able to be responsive to the need in Virginia. That's particularly true for psychiatry, which is a national issue that we have shortages of psychiatrists, and it impinges upon access to care for a lot of people. And as you mentioned, particularly in terms of the child psychiatry, part of the issue there is after you finish college, you got at least 11 years before you become a
that's
child
right.
psychiatrist with 4 years of medical school, psychiatric residency training, and then child psychiatric residency training combined a total of another 7 years. We also have significant issues in terms of what happens once the psychiatrist is trained. We have significant reimbursement issues. You talked about, the incomes that are there. And partly as a result of that, the vast majority of psychiatrists, at least in my part of the state in Northern Virginia, never set foot in a hospital. And many of them never take any insurance. That what they say is the reimbursement rates are so low that they cannot support themselves taking insurance. So what we have is actually people who have insurance who end up not being able to access someone who takes that insurance, and they end up having to pay out of pocket to the psychiatrist because that's the only thing the psychiatrist is taking because they don't have they can't use their insurance, which supposedly is providing that coverage for them. So there are, I think, a lot of challenges that are there. There are some things that I think that we are doing pretty well in, or certainly at least moving in the right direction. We've had several initiatives in mental health over the last decade and a half. And certainly I think the work of this commission is certainly moving us in the right direction in terms of restructuring our system and doing some of those types of things. We also have, I think that's helped build public support for mental health services, just the frequency of doing these things and keeping it on the front burner and keeping it in the public eye. We also have, I think, obviously a significant addiction issue in Virginia. And that also, we have built public support for being able to address that. And I think that puts us in a very good position. And I think it's helped break down some of the stigma associated with it because, at least in parts of Virginia, it is so commonplace that it's become something that everybody feels invested in. Everybody knows someone who has a problem there. We also are one of the leading states in terms of telemedicine, and telemedicine has proven to be particularly helpful as it relates to mental health services, and I think that's something that we can continue to benefit on. And some of the work that we're doing here, I think we, in working with the administration also, we are in the process of restructuring our public mental health and substance abuse systems, which I think in the end will produce significant benefits. So I think there are a lot of challenges that are out there, a lot of issues that gives us put us in a position where we really have to work hard. We can't just assume that these problems are going to go away. They're not. But at least we are doing some of the right things. And I think your input and the input of others in terms of what more we can do and your partnership with us and helping us be successful on some of the initiatives that we're willing to continue to work on, I think can be very helpful.
Yes, thank you, sir. I agree with absolutely everything you've said. And the gestalt of it is that there's more opportunity than there is obstacles, and collectively we can work better and harder and smarter in this.
Doug Davis, I think that's, thank you.
Doctor, so my question is, I'm concerned by the trend line we're seeing. Obviously, the demand for mental health services has skyrocketed, and it could be a number of reasons. And people with just always having access to electronics. When you talk about depression, anxiety, it never stops. When we were in school, you go home and that's your safe space. Now that doesn't exist anymore. So the concern is, I don't think there can ever be enough psychiatrists or enough that we need very quickly for this next generation coming up. If mental health issues don't always become mental illness. Mental illness you never really cure. It's an ongoing scenario that people continue to get support for. Mental health challenges are things that they get through periods of their life. Are there things we can do in the school that would help children cope with mental health challenges where it doesn't escalate to the point where they need to have access to the psychiatrist? So when you talk about depression or anxiety, I know one of our schools in Virginia Beach, a kind of a pseudo charter school, actually teaches yoga. It's K through 5, and they have a yoga once a week. Are there things we can do there that maybe alleviate that demand later on in life?
Yeah, that's a fantastic question. Thank you. Joel touched on some of it, so I'll be a little repetitive. I don't think there's any one thing that we can do, and it relates back to this issue of the kind of needle in the haystack. So you have all of these symptoms of anxiety, depression, concern, hyperness, but they're not necessarily mental illness of themselves. So how do we avert off what might be the symptom and on its way to be a mental illness, and then how do we detect what is a mental illness? So some of that is a combination of screening, and that gets to the kind of things that we might do with placing psychiatrists, psychologists, school counselors, nurse practitioners in the school setting where they have a watchful eye to be able to detect what's, if you like, routine distress in childhood with what's the emergence or risk of mental illness, knowing, of course, that things like family burden, addiction problems are going to make it more likely that that child is going to develop a mental problem as opposed to go through some transitory state. So there's that component, and then there's the way that we deliver care. And, that can be all the way from care and access at a school level to, as I mentioned, the ability to work with primary care providers that are really often a port of first call for mental health problems. And so having child psychiatrists that are not enough with, but having child psychiatrists work with family practice doctors where they top up that skill set and the ability for detection and intervention, work with primary care doctors, work with nurses in a more collaborative primary care model of care is just as important as having, building the workforce within psychiatry and psychology itself. So it's a whole menu and platform of activities that represent a commitment to detection, a commitment to prevention, and then a commitment to access and care directly.
Thank you. We have one more question? Sure. And the other question, you mentioned telemed and telepsych, and it seems Virginia is way behind the curve on other states when it comes to the allowance or the overregulation of telepsych, especially maybe where PAC teams and ICT teams come in and what you have to do. Is there, obviously you want to make sure that the treatment provided really provides what the client needs or those with the illness needs. Is telepsych an efficient method to provide treatment to someone remotely, or does a psychiatrist need to be there on site to truly get a real evaluation of what the client's going through or what may be going on?
So intuitively, you would say no, because there's a screen and a distance, and so in a specialty that's so connected, how could it be that being at the end of a TV is going to work and be as effective? We have actually done some research on this nationally, and we've actually involved it in some of our clinical trials in schizophrenia for evaluating people through telemedicine. And it turns out that once you are diligent to how you do your evaluation, it's, I don't want to say just the same, but it's essentially comparable to being in the same room. There are obviously some provisos in the sense that telemedicine breaks down for evaluating and treating somebody that's in addiction withdrawal. You can't do that at the end of a TV. You can do that if you have somebody that's there at the other end, but you can't be the primary. You've got to rely on the local source. It's also obviously less helpful in situations where people may be acutely agitated and at risk of spilling over into harm. You just, that's the use of telemedicine aggravates that situation, and it's a risky proposition. But by and large, even though it seems counterintuitive, telemedicine matches up pretty well with being regularly in the clinic, and surprisingly does so for acute situations like suicidality, where you can intervene and get somebody to come to another facility. I'd also point out that equally seems counterintuitively that in medicine, telemedicine seems one of its greatest approaches is actually for stroke. And you would think again that why would you subject someone in such an acute situation to that? But it's all about the options that you have in rural access, and it is surprisingly how well telemedicine fares out.
Delegate Davis,
Yeah.
I'll tell you that in 2015, the one pediatric psychiatrist who was serving 100% of the clients in the western Tidewater CSB catchment area moved to Florida. And she still served about 95% of the clientele by telemedicine. It's all we have in rural America, and not just Southwest Virginia, but Alaska, Montana, West Texas, lots of
Yeah, very much
areas
so.
in the West. I think Delegate Watts has a question.
Yes, but if I may first comment on the telemedicine issue. I spent about 5 years in counseling, a good portion of that twice a week. And at some point, it is extremely important that what you're dealing with is what you are dealing with, and that the counselor becomes an instrument for your facing certain things that you need to face and unravel and look at causality and so on, so that I can relate very well that at some point, when you're really going to be starting to heal and rebuild, that kind of what seems to be an impersonal relationship is in fact an important part of the whole process of dealing with it, that your counselor is not your best friend. They are in fact a professional. So I just share that from the consumer's point of view. The question that I had was that perhaps this is being taken up in our next presentation, but in all of your statistics there with children, what is the basic percentage where this is a situation, if even onto the third and fourth generation, where you have child abuse issues that are precipitating or exacerbating the child's mental illness, and you've got a real problem dealing with the parental situation?
I'm not a child psychiatrist, so I apologize if I don't have the statistics to hand. But the rates of anxiety, the rates of depression, the rates of social withdrawal and isolation in children exposed to childhood sexual and physical abuse are very substantial. And then they also, because of the formative stage of personality development, childhood trauma and abuse is an absolute disaster for the formation of a normal personality. And one of the more disturbing personality types in mental health is called a borderline personality, where people have intense personal rage and can't form meaningful relationships. And a large reason for that in lots of people with borderline personality is childhood abuse. So it's a very significant issue of itself. It doesn't explain the bigger picture of childhood mental health, but the prevalence and the disruption of mental health problems in abused kids is simply enormous.
And I would just underscore that then as we're talking about our schools and our need in our schools, that this has to be an element of it as well. We can't pretend that that's not going to be a portion of the problem for some of the students that we need to help.
Mr. Chairman.
Delegate Garrett.
Dr. Buckley, thank you for your comments. It strikes me that the greatest challenge is sort of the evolution of societal normative behavior. So my grandmother used to say, Daddy would turn over in his grave if whatever it is. They didn't even conceive 50 years ago of the evolution of this and sexting and bullying and juuling and e-cigaretting and all that stuff that and you mentioned that you talked about effectively situational anxiety or situational depression. It's still a DSM-10. It's still now diagnosed as that. I have 11 child psychiatrists within 3 miles of my office in Lynchburg, 5 hired by the hospital and 6 hired by the Community Service Board, and yet we still have all of those challenges in our school. And you mentioned yourself, we don't have biomarkers for a lot of what we would love to see eradicated in our, but I think the challenge is as society begins to accept these more uniquely different normative behaviors, in evolution, it creates a great difficulty for us to try to stay ahead of that game because we don't know what the next challenge is going to be. We're just constantly retrospectively reacting to the incidences as they come up, and they strum our heartstrings. When each one of these incidents happen, we as parents, we as community citizens, we all care about that. But I think it makes it very, very difficult for us to say, well, then the answer is let's just give more money to psychiatrists to create more psychiatrists. I got plenty in my city, and we still have got children in our schools, as Delegate Ranson has quite eloquently addressed, that are problematic. I don't know the solution. And then you mentioned, well, but we don't have a lot of medical students, that we only have 4% that want to go into psychiatry. I'm a trauma surgeon and an oncology surgeon because when I went through medical school, the last thing I want to do is become a psychiatrist and try to deal with all of those issues. So I'm curious to have you understand have a better sense of this evolution of what is becoming normative behavior in society.
That's a fantastic, it's a profound question, actually.
Most of my colleagues say the same thing. I actually ask a good question, so I'm just kidding.
As I was trying to convey, I do think there's an opportunity in trying to harness the innovations and situations that are before us, as opposed to kind of catch-up that you describe. I would say also in response to your very insightful comment is that we walk a tightrope between what Joel said about minimizing stigma and, if you like, normalizing the expression of human distress and therefore mental illness. As a profession, we also walk the tightrope with kind of medicalizing human emotions and expressions. And that's something that, as we try to understand conditions, it's hard to know what the boundaries of those are. And so, for instance, if you take, childhood attention deficit disorder, that really is the poster child for what you're describing, not described 30 years ago, or probably not as frequently described. That raises a question as to whether there was detection or not, or whether something in our environment is inducing more ADHD. But if you talk with school counselors, there's a great concern that psychiatrists, psychologists are coming in and calling everybody kids with ADHD, and then we're putting them on medicines that have growth retardation effects. So we grapple with this issue of kind of staying ahead of the curve, and then also what are those boundaries of what's a normal expression of behavior, what is human distress, and then what is, as we were talking about earlier, that pathway towards mental illness. And so it's a very challenging issue for us as a society, and it's challenging for us as a profession. Thank you for the privilege. Thank you for your leadership.
Thank you, Peter. Great questions, folks. Appreciate that a lot.